to today's APSC Cath Lab workshop, Beyond the Angiogram. The date stamp today is the 23rd of May, Friday, 3 p.m. Singapore time. This educational event is organized by the Asian Pacific Society of Cardiology, hosted at the National University Hospital, supported by the Singapore Cardiac Society, EBAC accredited for CME points in collaboration with Abbott. My name is Jack Tan, your chair for today from Singapore. This event is proudly hosted out of the Cath Lab for the live component from the National University Hospital. I'm very privileged to have my co-chairman, Professor BK Koo, who really needs no introduction. He's from Seoul National University, Korea. My speakers today include Dr. Bernard de Bruijn from Belgium. He's going to speak to invasive testing of the INOCA patient, something that we all need to learn more about. Our second lecture will be delivered by Professor Andy Yong from the University of Sydney, Australia. He's going to talk about the practical tips and tricks on CMD, CFR, and IMR. Our last lecturer is Dr. Peter Ong from Stuttgart, Germany, but he just emailed me and said he can't make it due to an urgent patient attendance. But we're going to speak to Acetylcholine challenge testing later during the live case, and we'll elaborate more on his lecture during the live event itself. My operators today include a friend of mine, Professor Adrian Low, Cath Lab Director at NUHCS Singapore. He will be assisted by his two able assistants, Dr. Kua Jieli, as well as Dr. Christopher Koo. The clinical coordinator today is Dr. Sim Hui Woon, all from the National University Heart Center. The panelists today include Dr. Eric Chan, Queen Mary Hospital, Hong Kong, Dr. Panipa from Chiang Mai Hospital, Thailand, as well as Dr. Takayuki from Gifu Heart Center, Japan. Please for upcoming webinars, 25th of May, we have an APSC Journal Club discussing insights from the latest journals and trials on TAVI for severe aortic stenosis. 14th of July, we have another webinar on pharmacotherapies in the management of HFrEF. Some disclaimers, this content is copyrighted by the APSC. The views and opinions expressed here belong solely to the faculty members and do not necessarily represent those of the APSC. The event is currently made live stream via Wonder, APSC Facebook and YouTube pages. CME points will be submitted for those who are connected throughout the full duration. You will then receive your certificate of attendance upon completing a survey sent by email. For the participants calling in live, please click on the Q&A boxes. If you have any questions, we'll endeavor to answer all of them. Let me state the objectives for today. One, we want to understand the basics of coronary microvascular dysfunction, coronary flow reserve, as well as the index of microcirculatory resistance and vasospasm testing, the role in this day and age. We want them to be more practical about it and share with everyone the practical tips and tricks on diagnosing and doing CMD, as well as vasospasm. We're going to perform all these objectives through a live case demonstration to illustrate the points. And we want to discuss the cutoff values to assess the entire coronary tree and interpretation of measurements. So let's get started. I would like to welcome Dr. Bernard de Bruijn from Belgium to deliver the opening lecture. Bernard, please. Bernard, we're seeing your screen in full. Please continue.
Prof, you're muted.
So Bernard, if you can unmute yourself, that'd be great. Bernard, you can unmute yourself. Can you click on the microphone?
Excuse me. So I just thanked you both, Professor Tan and Professor Koo, for this participation. It's an honor to be invited here at this distinguished society. And you asked me to speak of the, let's say, the invasive testing that we are performing most often in patients without significant coronary artery disease. And when we say coronary artery disease, we mean epicardial disease. And this is a typical example. It's a 50-year-old guy, sportive, chest pain, suggestive, but not completely typical of angina, like is often the case when we are dealing with epicardial stenosis. He has almost no risk factors. He was a former moderate smoker and has arterial hypertension, and his stress test is dubious. Now, when sent to the CT scan, the CT scan tells us that he has perfectly smooth coronary arteries. So we are definitely dealing with someone with chest pain, suggestive of angina, but not completely typical, and normal epicardial coronary arteries, the typical example of ANOCA patients or INOCA patients. And indeed, when we go to the cath lab, we find strictly smooth coronary arteries with even a little bit sluggish flow, but this is probably due to the slide. I cannot remember the flow exactly, but anyhow, the epicardial vessels are strictly normal. Now, when we are dealing with these patients, these kind of patients, we used to try to put them in boxes. And the four circles that I draw here, the left one is also very important. It is extremely important in these patients to be able to tell them, well, there is really nothing wrong with your coronary arteries. And very often this box, the left one, the normal, is underestimated, but for the patient it is extremely important. And for the moment, we have to admit that very often we think they are normal, so we try to persuade the patients they have a normal coronary circulation, but it's hard to really prove it. Now, of course, there are two other circles there with abnormal vasoconstriction and abnormal vasodilatation. This is what we are going to go more in details. And when it comes to invasive testing, the first step is, of course, to go to the cath lab and to perform a high-quality coronary angiogram. It sounds a little bit stupid, but the high quality is, of course, very important. And even more important in these patients, and this might sound a little bit old-fashioned or old school, is to perform a good elective LV angiogram. I see Bon-Kwon Koo smiling, because I see it's old-fashioned, but I really insist always to the fellows to perform an elective LV angiogram. It learns us a lot. And in these patients with atypical chest pain, it is important to be sure that it is not a LV hypertrophy. Of course, we have the echo, which is much better, but nevertheless, sometimes it did not have even an echo. But also the fact of being hyperdynamic. Hyperdynamic contractions may by itself elicit chest pain and are sometimes the only reason that we can find in these patients to explain their chest discomfort. So hyperdynamic contraction, LV angiogram. Now the second step is, of course, to perform an acetylcholine test. I heard that Dr. Ong will not be able to join, so maybe I will spend a little bit more time on this acetylcholine test. Yeah, this is something we discussed already. Acetylcholine test, here we go. The rationale of an acetylcholine test is actually a little bit the same as a wall shear stress mechanism. We are testing the function of the endothelium to see whether the endothelial function is normal. And you know that when the endothelial function is normal, we should expect a vasodilation of the epicardial vessel. When it is abnormal, we should witness a vasoconstriction. This is called the paradoxical vasoconstriction. And by the way, this paradoxical vasoconstriction, besides the acetylcholine test, is also something we should not forget in daily life, because these also happen, for example, when patients are exercising in cold weather. They can have this kind of paradoxical vasoconstriction. It's maybe not that frequent, but it should not be underestimated when we see these moderate lesions, typically in the LAD, 30–40% stenosis, and a patient describing typical exercise-induced angina. Well, the paradoxical vasoconstriction is not a myth. It is something which happens. Now, practically, this is how we perform the acetylcholine test in the Cardiovascular Center Aalst. we inject dosages of 2, 20, 100, and 200 microgram. We do that by hand injection over a period of time of 1 to 2 minutes. We do it like this simply because it is really very convenient, and I think that many centers have variations on the same theme. At the end of the 3rd minute, we shoot a good quality angiogram. We do that with a guiding in the 2 similar projection. We always repeat in the same order the 2 projection. And if the patient has no pain, if there are no major ECG changes, and of course no spasm on the coronary angiogram, we go to the next doses. Very important, nitrates should always be present on the table, and at the end of the acetylcholine test, whether or not a spasm was present, we give a big bolus of nitrates. In some centers, and I think that Dr. Ong is doing that systematically, he has a huge experience of acetylcholine. He also tests the right coronary artery with dosages or maximum dosages of 80 milligram. We don't do that. And what he also does is to re-challenge after nitrates. We are also a little bit too lazy to perform this. The test is already relatively long. And this is a typical example of a vessel which is strictly normal before acetylcholine and which show a long diffuse epicardial spasm when the maximal doses of acetylcholine has been given. And the definition of a positive test, acetylcholine test, relies on the fact that the patient describes symptoms, has ECG changes, and has severe reduction of the minimal luminal diameter of the epicardial vessels. It's not just a vague decrease in the diameter. No, it's a real severe 90% by eyeballing diameter stenosis. And another thing that I think very important is to ask the patient whether he recognizes his symptoms in daily life. If you say, yes, this is typically what I have sometimes, especially early in the morning, well, that's a major argument to demonstrate that what we are evoking there, we are provoking, is indeed the cause of his chest pain in daily life. If he says, oh, no, I never experienced that, it's completely different, well, then we might have some question marks. That one's for the acetylcholine test in a nutshell. Now let's go to the adenosine function test or the microcirculatory testing. Now you know that the microcirculation is the kind of black box we do not see, we do not understand, which is there somewhere behind the epicardial vessel. But it is important to realize and to keep in mind that this microcirculation is 90% of the volume of the total coronary circulation, 90%. So that's impressive already. And when we look at some essentials of the microvascular function, in one slide, a kind of, in a nutshell, the physiology of the microcirculation, it is important to realize that the quintessential metrics of the microvasculature is the resistance, the microvascular resistance, R mu. And R mu, microvascular resistance, is, at least during hyperemia, the ratio of the pressure, the distal pressure divided by the flow. And you see already immediately that the pressure is easy to measure. We have pressure-wise, they are extremely reliable, but the flow, that's really the difficult part to measure. The second point I would like to mention is that the flow and the resistance are extremely dependent on the mass. And then the last thing I would like to mention, and this is a little bit more tricky to understand, is that when the epicardial vessel is not strictly normal, and this happens all the time in the patients we see in the cath lab, they have mild diffuse coronary artery disease. When this epicardial resistance is abnormal, well, then the resistance of the microvascular at rest, without giving adenosine or papaverine or whatsoever, is already abnormal, is already lower than what should be the case, and this is due to the autoregulation. That's important to keep in mind for what we are going to discuss further. Now, there are several methods. I won't go into the details. This is the hyperemic microvascular resistance derived from Doppler and pressure. I have no experience, I must say, with this. In contrast, we have introduced already a long time ago, I think it was 20 years ago, the concept of bolus thermodilution, where we calculate the mean transit time. And as you can imagine, the mean transit time at rest is relatively sluggish, the flow is slow, and therefore the mean transit time is long. So the mean transit time is inversely proportional to the flow velocity. In blue, we have the mean transit time at baseline. In yellow or in orange there is the mean transit time that we can observe after having induced hyperemia. Of course, it is much faster, the flow is much faster, and therefore the mean transit time is much shorter. And you see the difference between rest, 0.49, let's say 0.5, and hyperemia, 0.2. So there is an acceleration by a factor more than 2. And indeed, the ratio of these mean transit time is used to calculate the coronary flow reserve, and also to calculate what has been introduced by Bill Fearon, the index of microvascular resistance. Bill said, well, if we have a surrogate of flow, which is the mean transit time, and that anyhow we have the distal pressure, which is the pressure at the entrance of the microcirculatory compartment, the product of both pressure multiplied by mean transit time gives us something which resembles resistance, which is an index of microvascular resistance. And that's why Bill called that the index of microvascular resistance, IMR. And we know now, or at least this is what we are used to assume, that when the IMR is larger than 25, and certainly larger than 40, that's not good news for the patients. The lower, the better. The lower this resistance, the better. This is, by the way, hyperemic resistance. It's an index of the hyperemic resistance. And therefore, you need a pressure temperature wire from Abbott. You need just a bolus of saline. So that's extremely easy, and which makes life even more easier is to have the Coroventis software available, because then everything is calculated on the spot. It takes 1 or 2 minutes to obtain this data. Now, we were stuck with this data, and we were annoyed because very often in daily practice, we see that these results are not very reproducible. And therefore, we tried to go a little bit further, and we introduced the concept of absolute flow and resistance measurements by continuous thermodilution. I will be very brief. I will not enter into the details, but just remind the following. We need to infuse continuously in the proximal part of the vessel saline at room temperature. Therefore, we need to connect a special catheter, an infusion catheter, to a pump which delivers, let's say, 10 or 20 milliliters per minute. Good. If we do this and we calculate and we measure, well, the computer or the wire will measure that for us. We measure the pressure, the temperature in the distal part of the vessel when the saline and blood will have been mixed, and that we know what is the temperature of the saline when it enters the coronary artery. Well, by a simple rule of 3, very simple, we can calculate the flow, but this time it is not an index, it is flow in milliliter per minute or in liter per hour. It's a volumetric flow, and that makes a whole difference. And this is a typical example. This is baseline. Here is the start of the infusion. You see that we reach a nice steady state. Then we pull back the sensor in the delivery catheter, in the infusion catheter, to know what is the temperature here. We stop the infusion and everything goes back to zero, to baseline. And this takes 70 seconds. So a little bit more than 1 minute. So it's not very difficult, but you have absolute flow. And since you have the pressure, you have also absolute resistance. Now, this can be done at rest. This can be done during hyperemia. This can also be done in one go, to have on one screen, in one, let's say in 3 or 4 minutes, resting flow, hyperemic flow, and therefore resting resistance, and hyperemic resistance. This is very simple. Again, not to confuse everyone, I will not go into the details, but it is on the basis of these type of measurements, continuous thermodilution, continuous coronary thermodilution, that we have recently introduced the concept of microvascular resistance reserve, which appears to be much more specific for the microcirculation than the classical IMR and the classical CFR, especially CFR. Now, we have preliminary data suggesting that when we compare bolus and continuous thermodilution in a large number of patients, and that we do all these measurements in duplicate, well, the reproducibility or the repeatability of continuous thermodilution derived indices like MRR or like the flow at rest and hyperemia is much more reproducible than when we perform that on the basis of bolus thermodilution. So again, bolus thermodilution, continuous thermodilution, there are pros, there are cons, but this one, the continuous thermodilution, is definitely more reproducible and quantitative and operator independent, which are non-negligible advantages. If you want more details about this, we published something last year in JCC Intervention, I think. Now, to come back to the patient, actually, you recognize that the 4 circles, according to the acetylcholine test and the test directed on the microcirculation, we can now exactly know in which circle these patients are. I'm not going to go into the details, but what is important is that if you do these kind of very sophisticated and specialized testing in the cath lab, you should also organize your practice with a specialized INOCA clinic. It means that these patients have to be followed up by someone, and at least this is how we are organized, someone which is not the guy who did these measurements in the cath lab, but someone who is able to integrate all these measurements and is able to convey this message, persuade the patients to remain on medications, explain the patients very well. This is what we call our INOCA clinic. And I will stop here, and I would be glad to have some questions and to discuss further.
Thanks, Bernard, for that excellent lecture. Bernard, do you mind if you stop share of your PowerPoint?
I will stop share.
We have around 10-15 minutes. I really want to get some comments around this topic. I suspect it took interventional cardiologists 10-15 years to get used to FFR. It's not as simple as it looks to get cardiologists used to CFR, IMR, and MVD, and INOCA. So I think there's a lot of work in terms of education to be done here. So maybe I'll start, Bernard, in your experience, you nicely illustrated a patient with cardiometabolic syndrome, 50 years old, smoking, diabetic, all the risk factors with INOCA. Is it true that this group of patients is the highest risk, or can patients have vasospastic angina without all these risk factors per se? Are we missing a lot of patients, Bernard?
Yeah. Let's say nowadays, it is almost slamming open doors to say that CMD, coronary microvascular disease, is extremely frequent. We miss a lot of patients. It's 50% of the population. Honestly, I think this is a little bit overhyped and a little bit exaggerated. It's like everything in the beginning, especially when we don't understand very well what's going on. We tend to say that it's extremely important, extremely frequent. I don't think it is that important. I would guess it's probably the case in 20-25% of the patient, but even this is quite important. But it is not, as sometimes published, 60%, 70% of the patients. But I would go on by saying that in our experience now, we find that more or less in 1/4 of the patients selected to undergo these tests. So these are patients who are already selected at the INOCA clinic. But these patients, it is so important to give them a diagnosis. whether it is normal or whether they have microvascular disease, or of course, whether they have a spastic problem. It is so important. And I must say 2-3 years ago, I was a little bit skeptic, even sarcastic about this. I'm now completely convinced when seeing the patients back at the outpatient clinic that it is really important for them to have a diagnosis.
I will agree with that. I think recently our patients coming in, they are really at the wall. They are very frustrated. They don't have a diagnosis. They are forming support groups on social media and stuff. Prof Koo, you have a comment to that?
Yes, so that this really was an excellent presentation about the INOCA, and which it can be quite complicated. So as you just mentioned, that if the patient doesn't have a significant disease and typical-ish chest pain, it may be simple. And if the patient have 80% stenosis, FFR 0.6, that's simple. But the problem will be in the middle. If the patient have a typical and atypical chest pain, FFR 0.78, and I think devil is there. So that do you have any kind of criteria, even FFR is between 0.75 and 8, where you perform this rather complicated procedures to define the mechanism? It's not INOCA, because the patient already have anatomically obstructive disease, but is there any way to discriminate the value of this test in anatomically intermediate at least patients?
Well, I will be very frank with you. We have no clear algorithm, but my day-to-day decision-making process depends for 90% on the anamnesis. And I have now a little bit experience with the years, I'm convinced that what he tells or what she tells is really very suspicious of angina. Well, then I go, let's say, I go on and we use a wire not only to measure the pressure and the fractional flow reserve and the PPG, but we go on and we do these microvascular testings. And when we do it nowadays, we do that systematically with continuous thermodilution to be absolutely sure not to induce a disease which is not present, which is even worse. And we consider that the minimal resistance during maximal hyperemia in the LAD should be below 400, 420. That's extremely reproducible. And I know what I'm going to say is a fishing story, but not later than last week, we had a patient who had bypasses already. The bypasses occluded. Then he had a long stent in the LAD. And over all these years, the guy said, well, you know what? I always kept having angina. And his complaints were typical. Last week, we measured the continuous flow. He had a microvascular resistance of 670 in the LAD. We say, Jesus Christ, we completely missed the ball in this patient, and that is his problem. Now, the treatment, that's another story. I fully agree.
So
but
I think there's a lot of questions popping out in the Q&A box about treatment. But I'm going to hold those horses. I have a few more questions to go around the panelists first. Prof Koo asked a very difficult question. We hope the live case can address that. But maybe we go to Eric before Andy. Eric, is there a gender difference between this subgroup, vasomotor spasm versus MVD? Do you see it more in males versus females in Asia? Eric.
I think typically we have those middle-aged female patients with atypical chest pain, non-obstructive coronary arteries on either CT coronary angiogram or invasive coronary angiogram. But I think they do share common risk factors with other patients with epicardial CAD. So I think if we do more testing, we will see more typical patients, male patients who have this kind of INOCA as well. I really have no confirmation regarding the sexual prevalence in my center, but I suspect we are underdiagnosing these patients with INOCA.
I agree with you. I'm going to go to Andy to take those questions first, maybe two of them. Jaspal Singh asks, is there any difference between an ergonovin test versus acetylcholine test? That's one. Second one is from Dr. Chen. She had a patient with high IMR over 40 but normal CFR. Is that abnormal? Should they be treated as microvascular angina due to the abnormal IMR? Andy?
So good questions. In terms of ergonomine versus acetylcholine, I think there's much more experience and data with acetylcholine out there. There are much fewer studies with ergonomine. However, the few studies that publish on ergonomine show that it is reasonably safe and can be used as well. We personally at our center use exclusively acetylcholine. We did explore trying to use ergonomine at one point when there was an ACH shortage coming into Australia, but it never eventuated, and we just continue using ACH. But from the operators that use ergonomine, they seem to have a reasonable experience with it. In terms of the risk factor profile, there are a few sort of published studies looking at the difference in safety, and it is said that ergonomine may be slightly safer, but in personal use, using ACH has been quite safe in our center. So that's my take on ergonomine versus ACH. In terms of the second question, it's a difficult one. So IMR versus CFR, what's the difference? CFR is a composite index looking at both epicardial and microcirculatory status. It also, CFR particularly looks at the ability of the microcirculation or the coronary tree to increase flow in the presence of hyperemia. Whereas IMR, it's more a measure of the minimum microcirculatory resistance. So it's slightly different, and there are slight nuances in the two. However, studies that have looked at the outcome in patients comparing CFR versus IMR show that if you have both abnormal IMR and abnormal CFR, you do the worst. If you have normal CFR and normal IMR, you do the best. And then if you have either or, abnormal one or normal the other, you do equally bad somewhere in the middle. So we don't fully understand or have teased out the various nuances in terms of prognostication and treatment of those two conditions, but they do separately indicate some sort of impairment to the microcirculation. One, if you like to put it, one is more structural and one is a little bit more functional. And maybe Bernard would like to add to that as well.
I would defer that to the live case. We'll explore that great question from UA a little bit more when we go to the live case. Maybe a last question for Dr. Takayuki. We'll talk about all this invasive testing. Is there any non-invasive test before the patient comes to the cath lab that we can try to do before they reach the cath lab for this group of patients in INOCA?
Yeah, thank you. Very nice question. I think before testing at the cath lab, we have several options. For example, perfusion MRI, also using adenosine stress. In that case, we can detect the endocardium site of the ischemia differ from the scintigraphy. So due to the very high spatial resolution, I think the perfusion MRI could be one of the options before cath lab testing.
Thanks a lot. Maybe I ask Panipa, can you use, because there are some ECG depressions, do you do any stress tests, or can you, for example, do even a Holter to look at SC depressions, especially if they occur in the morning? Panipa?
Yeah, so I would say that my center is quite poor center. So for the test, we can do just like SPEC, straight echo. For the MRI, the queue is like 6 months. Don't talk about PET because it's really expensive. So we can do just these tests, and if there's any documentation say that the patient got myocardial ischemia, so we just discuss with the patient whether the area of ischemia is worth to fix or not. So if the area of ischemia is less than 10%, so we try medications first until they cannot tolerate with the medication, or the we fail medication, we brought the patient to the lab and do the test. So we don't do the Holter monitor or anything else because the patient is quite poor and the cost for the patient to go to the hospital also the thing that they're concerned. So yeah, we don't have such a test. So we have to solely the EST, echo, and the spec.
No problem. Before we go to the cath lab, maybe there's a lot of questions on treatment, which are going to hold back until later. Maybe Bernard can take this last one. I mean, if you do any form of stress tests, the experience that a lot of these cases are missed, they are dismissed, and they get very frustrated. So maybe you can take that. Do you look at any non-invasive tests? Not everyone in Asia is like Japan, where you can do a perfusion MRI. But Bernard, your advice for non-invasive tests?
Well, I will surprise you, but the only non-invasive test for ischemia that I still do is a regular exercise stress test. The good old exercise stress test, for two reasons. Of course, there is the ECG, but also I like to see what the patient is able to perform in terms of exercise. And I like the simple conventional exercise more than a pharmacological stress test, because it's much more physiologic. And to see what the patient can do, and to see or hear the patient telling you, well, now this is the moment I start having pain, or reaching a very high level without any pain. These are elements, small elements, which are difficult to quantify. You have that on a stress test, exercise stress test, and you don't have that on a MRI, and not to speak of the cost. We have the same problem in Belgium. Don't worry, we have the same cost issues.
Thanks, Bernard. Maybe final word from Prof Koo, just back to the basics. Harris also asked, is there any specific features in terms of the chest pain, besides early morning, the kind of stuff that will make you suspect it could be vasospasm or microvascular disease? Prof Koo?
Yeah, so that if I answer some comments about the final questions, that but we have to understand that the clinical presentation, and there are several diagnoses under the area of INOCA, so that the chest pain presentation may be different. And vasospastic, typical vasospastic angina generally occurs early in the morning, especially after heavy drinking. So that's the key. And second thing is that it's just exercise induced spasm, or the walkthrough kind of a chest pain is one another a typical example of the spasm, or the exercise induced spasm type angina. So if I have some additional comments on this, is that as mentioned by Bernard, so that in the beginning there was a great interest in coronary flow reserve, and then we focused only on epicardial stenosis. And I also have to admit that in the cath lab, if there is no lesion, or at least no stentable lesion, or no bypass lesion, we generally think that it's fine. But we now understand that those are not fine, although we do not know how many is really there, but at least 10 to 20%. I agree that now it's time for us to focus more about forgotten 90% vasculature in patients with coronary artery disease, especially who have some symptom. But the future is the treatment. So I understand that we are going to talk about that later.
Thanks. We have a lot of things to talk about. There's still a lot of evidence-based gaps. Now we're going to move to the cath lab. So hopefully, in the case, we're going to discuss a lot more about the practical parts about how to do this. So Adrian, are you ready? Can you share screen from the cath lab, please? Can we share from the cath lab to the screen?
Jack, can you hear us?
We can hear you clearly, but please wait a moment while your Hui Wen shares your screen into the big one. Can you share from cath lab out as a share screen? Cath lab from NUH, can you share them as a share screen from NUH cath lab? Rather than we have to pin it because you need to share it. Yeah, now we can see you. So maybe Adrian, you can start by introducing your team for us.
Great. Thanks, Jack, for the invite, and greetings to everyone. So it's a pleasure to actually see so many experts on the panel. So I have Kua Jieli and Koo with me, who are my colleagues. And we have this afternoon an interesting patient who actually fulfills a lot of the symptoms that you see in your patients. And in fact, when Bernard was sharing his patient, we see a lot of similarities in terms of the patient's symptoms to our patient. So I'm going to just jump straight in and get the Dr. Koo here to share with us the patient's history and clinical profile.
Right. Okay. Do we have the slides?
Yeah, it's coming on now. You can start.
Right. Okay. So we have here a middle-aged lady, 48 years old. She's Asian. Again, she actually really came to clinic because of recurrent episodes of chest pain. So her episodes with chest pain and with cardiology started about 2011 when she was admitted initially for atypical chest pain. But really, her past medical history shows that there's a history of a dissection as well as a young MI. In terms of relevant past medical history for the patient, she is hyperlipidemic, she has hypertension, and she has Graves' disease as well. Her BMI is slightly on the higher side, and she's also actually got underlying obstructive sleep apnea. She's not a smoker, and she's non-diabetic. As part of her investigations before, I think we'll put up the pertinent ones, but the latest one showed an echogram of sometime last year with a normal ejection fraction and a slightly dilated aortic root of 44 millimeters. But really, the main point is for this patient is with regards to her chest pain investigations. So I think it started in 2015 when she was actually admitted for chest pain, and she actually was investigated with a myocardial perfusion scan then. And I think one of the scans showed that there was suggestion of ischemia in the LED, and therefore she actually had an angiogram. So with the angiogram in 2015, this was all done in an outside hospital, but actually it showed that there was no epicardial stenosis. There was no mention of any functional testing done in this outside hospital, but nevertheless, there were no comments on any obstructive significant lesions. Subsequently, I think she was discharged with follow-up, and she came in again multiple times to the different emergency departments with chest pain. Again in 2019, maybe a myocardial perfusion scan showing ischemia. And based on that, they actually underwent with a CT coronary angiogram this time, given the lower suspicion with a previously normal angiogram. And that expectedly showed that there was no evidence of epicardial disease and actually a normal calcium score. Why she comes this time again is that at the start of the year, she presented to the ED with the chest pain. And actually on functional testing again, this showed actually this time with a circumflex territory demonstrating ischemia. I think really in terms of the chest pain, I think like what Dr. Bernard was saying, it's always a mixed bag of features. So this lady actually described two types of chest pain. One was more of a chest pain on at rest, similar to some form of gastric reflux kind of pain. But there was another symptom that actually made her present to the ED, and that was more exertional in nature when she actually had left-sided chest discomfort, which radiated up to her jaw. So really that's where we're at now, a lady with multiple episodes of chest pain, previously normal angiogram in a invasive coronary angiography 7 years ago, 2 years ago, a normal CT coronary angiogram, but really with two myocardial perfusion scans actually showing ischemia in different regions. And I think that's where we're at today for this lady.
That's a beautiful case, Chris. And quite commonly, this group of patients are quite desperate with chest pains, actually. So, Adrian, maybe you go back to the cath lab with you there to tell us.
So we'll just get you up to speed on where we are now. So we repeated the coronary angiogram for this patient. If I can show you our angiogram this afternoon, can we just cue you in on it? So
yeah, so we're waiting for Hui Wen to share the NUHCS lab again. But this was indeed a very nice case that you're presenting, actually. Can I just ask a question of Chris?
Sure.
Bernard's comment was that, was the treadmill itself positive in this lady?
So
beyond the stress?
Yes. So I think unfortunately for both of them, they were all vasodilator.
Oh, okay.
Yep.
So not an exercise stress treadmill?
No, they were not.
Okay. Hui Wen, I'm still not seeing the cath lab. Can you stop share and share the NUHCS lab, please? So we can see them. Yeah. Now we see you again, Adrian.
Okay, great.
Go ahead. Yeah.
Yep. So can we just go back to the RO caudal diagnostic? Yes. The diagnostic angiogram. So basically, the right artery is normal. this is the left artery. I think you can see the aerial caudal projection. The LAO cranial, next picture. The jerky, yeah. Okay, that's your AP cranial, and looks like you can't seem to see the LAO cranial as well as the spider. But nonetheless, this indicates that there is no obvious angiographic stenosis, and you can see quite clearly from the aerial caudal projections, which demonstrate the LAD and the circumflex quite well, that they look pretty much normal. Now, what we have done is to advance the pressure wire into the LAD. Show us the final picture, please. And basically, what we're going to do now is to evaluate first for microvascular dysfunction using the full suite of hemodynamics as provided by Coroventi. And thereafter, we will proceed on to vasospasm study using acetylcholine. So you can see probably from the angiogram that we already have a pressure wire advanced into the distal LAD. And as is usual, what we usually do is to measure both the rest as well as hyperemic indices. So there appears to be some gradient even at rest. The rest PDPA in this case is 0.90. Can we just document that? Yep, just record this. Okay, great. And we also usually just do an RFR just to see how much it differs from the conventional rest PDPA. And I actually find this educational sometimes because there's a lot of controversy on rest versus hyperemic indices. So if you go by your rest indices, this might be abnormal. So we're going to now proceed to the conventional
Adrian, can I just
FFR. Yes.
Stop you there. What hyperemic agents and rate are you using?
Okay, so we use either intravenous adenosine or else intracoronary papaverine in our lab. Routinely, we would use intracoronary papaverine, but in a live case demo, I think just to offset the stress on everyone else in a rare instance of VF provoked during intracoronary papaverine, I decided I'm going to use IV adenosine in this case here. The patient has no contraindications to IV adenosine. So if the patient has a history of background severe poorly controlled asthma, certainly I will not be using IV adenosine. So I'm going to
maybe
yep.
for that point alone, we have some time, and yep. I mean the epicardial artery looks beautiful, and very surprised that the readings you're showing me is not 1.0.
Yes,
so,
that's right.
Bernard, you have a comment first for this?
Yeah, I have two comments. First, on papaverine, there is a kind of legend, urban legend, I would say, that papaverine induces ventricular arrhythmias. We have quantified this in a very large registry of 2,500 consecutive patients, absolutely consecutive. This is 0.9%. So we have to keep this in mind, but it's not a big issue. That is one. And then the small gradient, so to speak, that is visible there on the screen is related to several things. First, in the LAD, there is a hydrostatic, let's say, height difference between the guiding and the sensor, which might account for already at least 4-5 units of fractional flow reserve. So 0.04 to 0.05 units. And then there is a second aspect in the LAD. There is definitely, and I would not like to confuse everyone, but there is a tapering of the LAD, which is probably responsible for a natural small gradient in the LAD, taking into account that the volume of the vessel is a little bit smaller as compared to the mass than what it is the case for the right. So this is the explanation. And then the last thing is that there is very often hidden small irregularities that the eye cannot see on the angiogram. If you would do IVUS or CT, I'm sure that there will be atherosclerosis at several places there.
Yeah, allow me to supplement. I think
yes, Eric.
Yeah, sometimes we underdiagnose myocardial bridging as a cause of obstruction in the epicardial coronaries as well. And typically, we need to give the albumin stress test to provoke those diastolic FFR gradients, but sometimes it's already angiographically evident after nitrate injection.
So the other comment, urban ledger or not, I have induced BF with papaverine before, though it's rare. So I think it can unfortunately happen. Adrian, back to you.
Okay, so we're going to just proceed to how we would evaluate the coronaries conventionally. So Chris here is going to just demonstrate to us. So we're going to go over to the CFR. So we're going to do the rest hemodilution. So we had earlier given GTN. Also, one of the reasons why we gave GTN earlier was to make sure that there wasn't spasm accounting for the baseline difference in gradient. Okay, so Chiang, would you going to do it? So it's injecting the 3 mL of saline bolus at rest. I'm not sure if you can see on screen. Do you want to engage the guide a little better?
Yeah, we can see on the screen.
Push your guide in.
Maybe we go to full screen, we went on to the Corovantis system alone.
All right, try again. Okay, ready, Evan? Yep. So one of the practical points in doing your thermodilution studies, you have to make sure that your guide catheter is selectively engaged. Sometimes, you know, if it's not well engaged, you're not going to get your saline bolus down. So having a good guide catheter engagement is actually essential.
Feel free to jump in from my panel if there's any comments or.
So that's the first number we got, 2.36. Next.
What would be a normal range, Adrian? Maybe you'd like to tell us.
Usually we see something between 1 to 1.5. This is a little slow.
Is there a normalized range that we all agree upon? Is there a difference between anything, whether it's velocity, weight, BSA?
Okay, Aaron. Yeah. I'm not sure that there is a definite normal range.
Prof Koo?
Yeah, repeat the 2. Yeah.
Do you have any comments on the range?
I agree that it should be around 1 point something, but if it is more than 2, that's slow. But as you just see that while Adrian's team is pushing more and more saline, you see that the number gets lower and lower.
Yeah.
So there's a possibility that the saline injection, Bernard can definitely know more about that. Saline injection can induce hyperemia in some cases. If you have a repetitive injection, you will increase the blood flow to this patient. And another thing is that this may be a kind of error, so that while doing this kind of analysis, you see that those 2 blue and white lines are now being separated, so that this sometimes happens while we're measuring the resting and hyperemic saline injection, so that there may be a cause of And another thing is that just Adrian mentioned that the resting measurement is tricky, because that the guiding catheter sometimes is popping out while injecting the saline, and that sometimes underestimate the resting flow. So there is several technical and mechanical issues about this.
Yeah, all excellent points here that you elaborated, Dr. Koo. So if we will go to
Andy, do you have any comments? I don't want to preempt you on your tips and tricks, but anything else to add on to Prof Koo's comments on the tips and tricks?
No, not at this stage. I mean, one thing to say is that the resting flow, I mean, Adrian is being very diligent here in trying to get the numbers quite close to each other, but often, they can vary quite a bit, especially in the resting states. And in our large registry data, we tend to accept anything that's within 0.25. We looked at the variations of the resting flow and the hyperemic flow. And for the purposes of like our randomized controlled trial, we decided that if it doesn't deviate more than 0.25 from the mean for the resting transit time, we're going to accept it.
Dr. Takayuki, do you have this Corovantis system in Japan?
Yeah, I'm using now. And before Coroventis, I also used to use the pharma style of the Abbott products, pressure wire salters. I also performed CMD measurements in many cases. And I totally agree with Dr. Koo's technical pitfalls, especially in injection. The average moderated injection style is very necessary for accurate measurement of CMD. And several times we often encounter the disengagement of the guiding catheter if we inject very strong. In that case, you should be very calm down and try it again. I think that's the tips.
So Chris needs to be performed like a machine. Bernard, you have a comment before we move on?
Well, yeah, I think that the demonstration performed in the lab was extremely interesting, because this is what happens all the time with IMR and bolus thermodilution. You have to repeat it a number of times to find three values which are sufficiently close to each other. But for me, this is a major pitfall of the method, because actually what you are doing, you are cherry picking the value which suit you, and you reject all the values which are, let's say, outliers. And this is what is the major advantage of continuous thermodilution, is that you switch on the pump, and then you can go in the kitchen, drink a coffee, and when you come back 2.5 minutes later, everything is on the screen. You did not touch the patient. And that's, for me, very annoying. I also agree that it is less the case during hyperemia than at rest. And that's already reassuring by itself.
Thanks, Bernard. Excellent comments. Adrian, back to you. What is the next step then? Yeah.
Okay, so the next thing that we're going to do is we're going to make sure there's no coronary spasms. So we're going to give nitrates, 200 mics of nitrates. And then we're going to also now start the IV adenosine infusion. So as another just point of note for those who are just starting out is that if you're giving IV adenosine, just keep in mind that there is a dead space in the tubing. So most times the average tubing in our lab here is about 4 mil. So we would generally push 4 mil first before we start the infusion, just so to get rid of the dead space. And we also would start a timer just to make sure that we have given enough time for the IV adenosine to work. Because if we do not give enough time, you're not going to have maximum hyperemia. And that is the basis of your FFR. Okay, have we started? Yeah. So IV, the intracoronary GTN 200 mics has been administered. And we have also started the infusion of IV adenosine. Is the timer available? Okay, great. So we're 20 seconds now into the infusion, and you can see the PDPA ratio is 0.89. So we'll just carry on and we see whether it actually diverges.
No problem, Adrian. We wanted you to show us this live and also take it slowly. We do have time. And we want to show
one of
everyone,
the challenges among interventional cardiologists is that interventional cardiologists are generally impatient people. So what I find is a lot of times people don't wait long enough to have maximum hyperemia, and they just accept the value as is. So I'm waiting for at least a minute to a minute and a half before and getting a consistent PDPA ratio before I'm convinced that we have adequate hyperemia. Of course, all the time monitoring the patient's hemodynamics and symptoms.
Yeah.
So
do you watch the ECG? Do you watch the ECG at the same time?
We are actually monitoring the ECG now. We don't see anything.
So perhaps, Hui Wen, you can switch to the one with the ECG and see whether there's any changes.
Okay, we're gonna. It's moving to 90 seconds now. We're gonna start administering your saline bolus. Go ahead, please. So you would expect that the hyperemic time to be much shorter. So 0.04. That's really very, very short. 0.19. Okay, we're going to repeat the 0.04. Presumably that's the outlier. And as I concede with Bernard that this is one of the challenges with doing things like this. There is this operator variability that we try and minimize as much as we can. Just repeat that point. Now, which one we're going to repeat? Let's just repeat the 0.19, you see? Not that's going to make too much of a difference.
What is the difference that you is considered
Okay, let's just
significant?
repeat the 0.07. Yeah. So usually anything less than 0.1 is really very, very short. So it's usually an error. I think this is reasonable. Yeah, we can just click end there. And then what we usually do now is that we go to a full FFR tracing and we do a pullback. So this is something that we would do it under fluoro. Yeah. Okay, do a pullback. Okay, start your marker. Good. Pullback.
Can we see the screen? Yeah. So pulling back to the mid now.
Yep, that's right. Yeah. Okay, good. So it's 0.97. I think it's pretty close to where it was baseline, but it's just basically for us to exclude significant pressure drift, which will make you wonder if the measurements you've taken previously was significant. So if you look at the Coral-Venti screen now, we have an FFR of 0.86. Even taking into account the correction, is clearly in the normal range. Your coronary flow reserve is measured by thermal dilution is 7.5. Your RMR is really well within normal limits, 13. And there's this new index called the RRR, again, the very high, 8.6. So basically, I'll say that in terms of your conventional evaluation for microvascular dysfunction, we have not actually demonstrated anything abnormal. So we're going to now move on to the vasospasm provocation test. Do you have any questions before we proceed to the next phase of our evaluation? In the meantime, Chris is going to just send the pressure wire down into the LAD.
Yeah, so this is a good pause actually to ask some questions from the audience. Dr. Dai from China is trying to ask Bernard. So he says in China, they don't do acetylcholine tests. Is there any examination as an alternative? And what is the ratio of someone who you test for acetylcholine challenge that becomes positive? Is it like half of your patients or more? Bernard, do you have a...
It was to me, sorry.
Yeah.
Well, I'm not a specialist of the coronary vasospasm, but in the past we have used ergonovine, as alluded to already by some other participants to the panel. We have used ergonovine, which is, by the way, very convenient because it has to be done intravenously, not intracoronary, otherwise you will have catastrophes. But it's very convenient, and in our hands, we had the feeling it was very safe too. So it's certainly an alternative.
Great, thanks.
And a question from Yen San, actually, maybe to Adrian or anyone who does this. Is there any difference in using a manifold versus a power injector console for the saline injection in order to keep it constant? Do you find a difference? Do you do a manual injection, or can you use a power injector for the saline injection as well?
We use a manual injection, so we just find that it's much more convenient. Yeah, because so our system is not connected routinely to a power injector. Yeah, and I guess you could use a power injector, but for 3 mil saline, I'm not sure. It's a lot of effort to set it up.
Yeah.
Andy, Eric, or...
So Professor Low, I saw that you're using femoral access. Do you routinely always?
Yes, no, I routinely use a radial, but this patient had a painful experience from her last transradial access, and she insisted that we not approach a radial artery. So yeah, that's why we actually went with a femoral access here.
All right,
yes,
then
but
do you skip the cocktail
used...
then during radial access? I mean, and what do you have verapamil and nitrates or only calcium channel blocking the cocktail? So that vary from place to place, I assume.
Yeah, so that's a good question. We sometimes use GTN nitrates, but I know there are always concerns whether you should be using nitrates or not prior to all this testing, but I'll take it that it's relatively short acting. And if there's a active concern with vasospasm, yes, sure, you may not want to even administer that minimal amount of nitrate for the radial artery.
Adrian, where are you now? Can you tell us a little bit? So you have demonstrated that this patient has relatively normal indices
Yes,
for
that's
both
right.
epicardial and microvascular circulation, I guess.
Yes, so what we're going to do now is to see if we can provoke coronary spasm. Okay, so before we do that, maybe we could just cue you in on the video on the dilution of acetylcholine, which has been prepared by Hui Wen. And I think this might be of interest to a lot of our colleagues who are just starting out because there are some nuances in acetylcholine dilution. Now, just to highlight that the protocol that I'm using for the acetylcholine provocation is based on Peter Ong's protocol because he has the largest experience to date. Unfortunately, he's not available this afternoon with us. But nonetheless, we'll just share with you what we do. Over to you, Hui Wen.
Yeah, so perhaps I can, oh, Hui Wen, you have it? Okay, great. Hui Wen, you need to share the audio part of it as well before it can work when you share screen. So you need to stop again, get out and share. If not, let me try mine. Let's see.
Good afternoon, everyone. I'm Hui Wen. I'm a consultant cardiologist at the National University Heart Centre, Singapore. And today I will bring you through the protocol of preparing acetylcholine injection for vasomotor studies. This is a step-by-step approach. Step 1, you need to prepare your stock solution. This is followed by preparation of the dilution syringes. And finally, preparation of the dose syringes for administration during the studies. Step 1, preparation of stock solution. For this step, you need your reconstituted acetylcholine solution and 2 bags of 100 ml saline and label them as stock 1 and stock 2. Next, remove 2 ml of saline from stock 1 and 9 ml of saline from stock 2. After that, mix 20 mg of acetylcholine with 2 ml of solvent that is provided in the packaging, and this will give you 20 mg over 2 ml. After that, we draw 2 ml from the acetylcholine solution and mix with stock 1, and this will give you a concentration of 0.2 mg per ml. Next, we draw 9 ml from stock 1 and mix with stock 2. This will give you 18 microgram per ml. After that, you can discard or leave aside acetylcholine solution and stock 1 as you don't need them anymore, and we will use stock 2 for the next step. Step 2 is the preparation of dilution syringes. For this step, you will need your stock 2 and 3 50 ml syringes and label them as high, medium, and low. For the high dilution syringe, we draw 40 ml neat from stock 2, and this will give you the exact same concentration of 80 micrograms per ml. For the medium dilution syringe, we draw 8 ml from the high dilution syringe and mix this with 32 ml of saline, and this will give you 40 ml of solution that is 3.6 microgram per ml. For the low dilution syringe, we draw 4 ml from the medium dilution syringe and mix this with 36 ml of normal saline, and this will give you a concentration of 0.36 microgram per ml. Step 3 and the final step is preparation of those syringes for administration. For this step, you need to prepare 3 5 ml syringes and label them as 2 microgram, 20 microgram, and 100 microgram, and 1 10 ml syringe and label it as 200 microgram. To prepare the 2 microgram dose syringe, remove 6 ml from the low dilution syringe, and this will give you 2 microgram. For the 20 microgram dose syringe, we draw 6 ml from the medium dilution syringe, and this will give you 20 microgram. For the 100 microgram dose syringe, remove 5.5 ml from the high dilution syringe, And for the 200 micrograms, remove 11 mils from the high dilution syringe. If you need to perform vasomotor study in the right coronary artery, you need to prepare a 80 microgram syringe. For this, we draw 4.5 mils of solution from the high dilution syringe, and this will give you 80 microgram. So this is the summary of the syringes for administration. So you have your 2 microgram, 20 microgram, 100 microgram, and 200 microgram. These are the actual dosage that you get. And you should administer every syringes in a 1 minute interval and over 20 seconds, except the 200 micrograms, where you should administer over 20 seconds to 3 minutes. It's important to note that at every step, you must always check and verify the medication dosing with another colleague to avoid error. And remember to use the solution within 2 hours of preparation. Thank you.
Thanks, Hui Wen. Very difficult process, I can see. And, is there any way to make it any simpler? I'm asking whether anyone has any other better dilution formulas.
I think once the nurses have gotten used to it, it's actually quite straightforward. I know initially it's a lot of tedious work, but I think the steps are important, especially when you're doing serial dilutions to very low concentrations. I think this is why it's important to stick with it, because if you're not doing careful dilutions, you're not going to have the concentrations that you desire, and that's going to make your interpretation difficult. So after about 1 or 2
sorry, I
attempts,
just
yeah.
interrupt you. Can Hui Wen share the Cath Lab as a main screen, because it's still not shared? We cannot see Adrian. Yeah, thanks. So Adrian, we can see you now.
Okay,
So
do you want us to proceed?
Yeah, please proceed. Yeah, now we can see you.
Okay, so what we will do now is basically we're going to do a baseline angiogram, and I would recommend that we use the RO caudal projection. So the reason why you want to do that is that this allows you to look at both the LAD and the circumflex from a single projection. And you also will want to look at the ECG, and you want to also document the patient's symptoms. Okay, let's just do a baseline picture first. I'm not sure
So
if you can see
let's
the
go
angiogram.
into the P&P screen. And then Andy, you have a comment for
Okay,
the Cath
are we
Lab
ready?
team?
Yep, single plane.
Yes, I was just going to say that there we have a different sort of protocol that makes it quite simple, but maybe we watch Adrian and his team first before we go on to that.
Yeah, okay,
Sure.
thanks.
Okay, so that's the baseline, which was pretty much similar to what we had before. So this is before we administered anything. So as per our protocol, so can we also record the ECG? So this is the 12-lead ECG at baseline. So the patient is asymptomatic. Yeah. So this is your 2 micrograms acetylcholine. We're going to administer it intracoronary. Floral. Yeah, floral. So I'm giving it over about 20 seconds off the floral. Yeah. And usually during the administration, you might see some transient ECG changes. Does the patient have any symptoms? Okay. Little bit.
So usually, do
Starting
you
to
see
pain
the
a bit.
ECG changes first or
Yeah.
chest pain first?
You can see the ECG changes, right? There's some subtle T wave changes, yeah. And the patient has some symptoms. Okay, let's take a picture. Okay.
So a positive test here needs chest pain ECG changes or demonstrated vasospasm, or just 2 or 3?
Well,
1 or
ideally,
3?
you want to have all 3.
Okay, very fast.
Yeah. Okay,
Slowly.
so I don't see any obvious angiographic changes, albeit the patient has some symptoms and there are some subtle ECG changes. So we're going to now proceed on to the next dose, which is the 20 micrograms, which is again a relatively lower dose. Okay, can we record the ECG? Have you recorded the ECG? The 12 ECG. You have, right? Okay, good. Okay, I'm going to administer the 20 micrograms now, just follow. Okay, again,
over how many seconds do you give?
Over 20 to 20 seconds to 60 seconds. No, just give it slowly. You can probably see me administering it now. And then while you're administering it, you want to look at the ECG. You see there's this transient heart block, which is one of the commonest effects that you see with acetylcholine. Usually not an issue. Yeah, just comes back out. So if you see that, you just slow down your injection. And in any case, you have your nitrates or your atropine on standby to reverse any adverse effect. Yeah, so her heart rate is slow because of the acetylcholine. This is to be expected. How is the patient? Does she have any symptoms?
You okay, Mr. Smith? You okay?
Does giving atropine fully attenuate further testing with acetylcholine?
Pardon?
Does giving atropine, if they really go in a prolonged,
I think you would have established your diagnosis. But usually, we're going to take a picture now. Yeah. Okay. We've not had to do that.
Okay, so no obvious.
Nothing yet obvious. So that's at 20. So we're going to increase the dose now to 100. Have we recorded the ECG? Good. Just give me more GTN. Stand by. So you very rarely have to use atropine. Most times you're going to just reverse the effect with nitrate. Okay, can we just follow? Okay, so I'm giving 100 mics now. Okay, just off it.
Bernard, please go ahead.
Well, I know that the Japanese colleagues who have a lot of experience with acetylcholine systematically use a pacemaker or place a pacemaker, probably for this reason. We don't do it.
Is that true? I need to find out from our Japanese colleague whether that's true though. Dr. Takayuki, do you put a temporary wire in? Maybe you'd like to unmute yourself first. Dr. Takayuki, you have to unmute yourself first.
Oh, sorry. Thank you for asking. When we use acetylcholine as a spasm provocation test, we basically use a place temporary pacemaker. Instead, when we use ergonovine, in that case, we don't have the pacemaker in the patient, basically.
You can see the pulse is getting longer, which is expected from a higher dose.
Is that the practice for Eric as well, Panipa? Or Prof Koo? Do you put a temporary wire?
No, I inject slowly and watch for AB block before I push further instead of putting a TEM line, unless I'm doing that on the right coronary, which I seldom do.
Good. Okay, record the ECG.
I don't have acetylcholine in Thailand.
Yeah, Prof Koo, please.
I'm sorry, I can't hear.
So in Korea, so there's a half and half acetylcholine and ergonovine, so that you're more use the ergonovine. And during the ergonovine test 10 years ago, we used to have a pacemaker backup, but now we don't.
Huh? Or different?
No different. Okay. So the patient actually does have, so we've administered 100 mics, and the patient does have provoked symptoms. Although the ECG doesn't show much, and I don't see any significant angiographic significant stenosis on the angiogram. So we're going to administer the highest concentration now, 200 mics. Okay, so this we're going to give really slowly. Okay, just slower.
Yeah, please do. Love to watch you give it slowly. Control we are very patient people here today. Andy, you have a comment?
Yes, I was just going to say that we've done many tests on the left coronary system and haven't run into problems. And recently we've started doing the right coronary artery as well. And it is quite clear that you will need a temporary wire if you're going to do the right coronary artery.
That's a great comment. So we're going to watch with bated breath. Prof Koo, your comments?
Andy, what is your explanation for this difference in the right?
I think it's perhaps just the fact that the right, it's supplies more of the sinus node and the the AV node as well, and seems to be much more sensitive. Maybe also the smaller volume of the right, although we give a maximum of 50 and sometimes go to 80 mics, not 200 mics, but still we get a lot of patients with significant bradycardia. And we think, there was this question of, all of them come back anyway. Like, do we really need the temporary wire? But when we inject the right, we see them like having prolonged pauses of more than 5 seconds very commonly.
It's interesting that the right is sensitive to adenosine, to also continuous thermodilution, to rotablation. It's always the same vessel, but by different mechanisms, probably.
Yeah.
Probably there is one mechanism that we miss, one common mechanism. It's not very likely.
When can you share the cath lab screen, please?
May I ask one question?
Yes, Panipa,
Yeah,
please.
just only one basic question. So do you systematically inform the patient that do they have to stop caffeine before go to the test? Do you believe that the caffeine increase the FFR result and also will affect the CFR and IFR value? Maybe
Adrian, do you have an answer to that? Did this patient have to stop caffeinated drinks?
We don't usually routinely, but that's a good point. But most times the patients are fasted for quite a few hours.
When can you share the ECG and the screens, please?
So we're done with the 200. We're going to take a picture now. Picture.
So we don't quite see any ECG changes. We missed out a little bit.
Yeah, that's fine. Yeah. Okay, we can give the GTN now. I think we can just. I think we've given enough. 200 of GTN.
So I don't see much of ECG changes or vasospasm or angiogram.
Yeah. How are you? Better.
Is that correct, Adrian?
Better.
Okay, good. So there are some subtle ECG changes. So if you consider those ECG changes to be significant, then in the presence of symptoms, even though there is absent coronary spasm on the epicardial coronaries, you might say that this is positive for microvascular spasm. Does anyone want to comment on this?
Maybe Andy or Bernard. Is this considered positive or negative?
I agree with Adrian. I mean, in the absence of a 90% epicardial vasoconstriction, you have ruled out epicardial coronary vasospasm, but the patient had symptoms and some subtle ECG changes. You can classify them as having microvascular spasm. The other issue, obviously, is that, and it's a contentious one and one for debate, is the question of whether you should now go and test the right.
Yeah. But yeah, in this case, the right will be a small vessel, I think. And there is another small detail, and maybe we didn't look enough or in enough detail, but the PDPA went from 0.89, 0.90 to 0.9697 during your administration of acetylcholine. Since the acetylcholine is very short lived, I have the feeling that it is an argument to say that there is microvascular spasm here, indeed. And this went along with these ST depression. If the PDPA goes up, it simply means that the flow decreases. And I have the feeling that this happened a bit in this patient. Of course, these are small details. This is not obvious. I fully agree. But we should learn to read all these small details in these patients. She did not have pain.
Prof Koo, for yourself, is this positive or negative?
I should say, by definition, I would say that it's negative, but I would also consider the possibility of the kind of exercise the spasm or the microvascular spasm, but it's tricky unless the patient really have a true ST segment elevation with the typical chest pain. It's tricky, and Peter Ong did this a lot with the repeated acetylcholine testing after nitroglycerin, and in that study he also showed the cases with the ST elevation chest pain. But I should say that this is kind of a real representation of real world practice where nothing is black and white, something in the middle. So we have to consider all the other possibilities for the patient's repetitive chest pain.
Andy, you have a comment?
Can I just ask, was the nifedipine withheld in this patient for this test?
No, it wasn't. No, the nifedipine was not withheld.
So yeah, there is debate. I mean, if you ask, amongst the Australian, we are trying to come up with this protocol and consensus of how to do these sort of tests. And there's still debate. 50% of us say that we have to withhold the vasodilators before the test, especially if you get an improvement in symptoms while on the vasodilators. But another 50% say you don't have to withhold. But I think, it may be wise to withhold some of the vasodilators, especially if it makes a difference to the symptoms, because it may muddy your test a little bit. I'm interested to hear what the rest of the panel have to say.
Yeah, that's a great point, Andy.
That's my usual practice too. Sometimes I even go too far to withhold them for at least 2 days. The nitrates and calcium channel blockers. Beta blockers and ACE inhibitors, I'm not particularly sure.
Okay, Dr. Takayuki, would this be also a positive or negative test in your lab?
Yeah, I agree with Dr. Koo. By definition, this would be negative. However, we must still consider microvascular spasm or something like that. And I also concerned the effect of the calcium channel blocker is not withdrawn before this testing. It might affect the result, I think.
Would Adrian move on to the challenge on the RCA then? Is it useful?
I probably won't, because the right coronary artery is relatively small. So I think those were excellent points that were highlighted. But in general, I think the calcium channel blocker that definitely should be withheld would be things like diltiazem and verapamil. I'm not so sure about dihydropyridine like Adalat LA, because generally you want to treat vasospasm. It's not a drug that you want to increase. Rather, you would actually administer diltiazem or verapamil for the coronary spasm beat. But those were the good points that are worth considering. But I think at least we have established that she doesn't have significant epicardial stenosis or microvascular dysfunction. And now the issue is whether she might also have a microvascular spasm as cause of a symptom. Now, in light of this, probably it's best to avoid a beta blocker in a subsequent management. And maybe the plan is to escalate or add on the diltiazem or verapamil to a treatment and follow up her symptoms accordingly. how does the panel feel about this?
Yeah, we haven't quite gone to discussion on treatment. We want to focus after Andy's lecture. But
Sure.
there are a few points from the audience. Maybe address that, then a question for you back about the actual final diagnosis for this patient. So there are some questions from Gabriel and Harris again. Do you necessarily perform the vasodilator component before the acetylcholine challenge, or can you do vice versa?
Actually, no more veterinary.
Is it better to do one after another? And how long do you have to wait after giving adenosine before you give it acetylcholine? Is there a difference?
Yeah, I think those are good points here. But I know that in some centers, they would actually traditionally start off with the vasospasm study first. But in our center here, we actually do the microvascular dysfunction study first because we just find it a lot more practical. And I'm not sure that one is necessarily better. And I think that's one of the challenges that plague this view, because the protocol for this testing is really very widely varied and differs from institution to institution. So this might actually have some difficulty in interpreting which protocol you want to follow. But in our center, we currently am sticking to this, partly also because we have only recently moved on to using acetylcholine provocation spasm as part of our repertoire of evaluation of the microcirculation because of its availability. And by and large, I think, at least in our center, if the patient has demonstrable abnormal microvascular dysfunction, we may not necessarily proceed on to the acetylcholine provocation study.
Yeah, I think this is a great point because it is so tedious to dilute and prepare acetylcholine. I think Andy will share with us a simpler way, but once you prepared it, kind of difficult not to use it. So I wonder whether people use that first before the first 2 hours of preparation or not before this dilatation. Maybe I'd like to sum up by asking my panel what is their final diagnosis based on normalish indices followed by a borderline challenge and their recommended treatment. Maybe we can start with Bernard first.
I would consider this test as negative. We have not enough arguments, and I think, especially in this kind of patients, it is important to avoid overdiagnosis and to reassure these patients. Even if she has microvascular spasm, well, this might be treated medically. We must keep this in the back of our mind, but I would not enter the room in this patient and saying, well, we have found what you have this and you have that, and you have to take this medication. So I would try to demystify a little bit the problem.
Thank you. That's a great point. Dr. Takayuki, your diagnosis and recommended treatment.
Thank you for asking. I also think the result is negative. And if this patient is for my patient, I will explain precisely, accurately, and sincerely the results, what we've got for about maybe 10 years. So I just advise this patient to modify the lifestyle and including the treatment of dyslipidemia and hypertension and follow up about the symptom. That's all. Thank you.
Thanks. So great. Eric, your diagnosis and management.
Yeah, I think I think there is absence of microvascular dysfunction and probably negative acetylcholine challenge testing as well. What concerns me is the abnormal baseline PDO for PA and the RFR, which is kind of in the gray zone, and also the dilated aortic root. So maybe poorly controlled hypertension. And also, if you want to pursue further, you might want to do some imaging of the LAD or the coronary, like intravascular imaging, to look for any diffuse disease that we missed it and aggressively manage the patient's risk factors, especially in the family history of aortic dissection, and the aortic root is probably a little bit dilated for her age.
Thanks, Eric. Panipa?
I would say to her that that is a negative. I think she got hypertension, but if I would like to modify some of her medication So I think for the nifedipine, to me, I would prefer to change it either to verapamil or to divarasib.
So still thinking that there's some microvascular dysfunction. We have the final diagnosis from Prof Koo then before we summarize this case.
So I cannot say that this is my final diagnosis, but what I want to say is this is very important to perform all this analysis. And when we don't have a clear answer, I think we should try to find the source of chest pain outside the heart, such as a lung, esophagus, and GB. Sometimes we find a lung cancer close to the spinal nerve, or sometimes we find in. And if this were my patients, and if the patient the patient already had a CT scan for coronary artery disease, but my routine is that evaluate esophagus, chest by CT scan, and gallbladder, and then seriously consider the consultation to psychiatry. So that's my routine. So it's not related to this patient, but because when I'm not clear about the diagnosis, I'm thinking about all the possibilities for this repetitive chest pain, which causes the patients to visit frequently to the emergency room, because that's a serious problem to the patients and her family.
Thanks, Prof. That's very wise. So Adrian, this is your patient. Perhaps you'd like to tell us your final diagnosis and recommendation before we close from the cath lab.
Yeah, I think those were excellent points there. While she certainly does not fulfill the classic criteria of demonstrable vasospasm, she did actually have provoked symptoms that was relieved with nitrates. And I guess the question is the subtle ECG changes. Now, while I may not necessarily tell her that she has something obviously abnormal, but it's also good that we reassure her that most of the indices that we have performed, in particular the microvascular as well as epicardial evaluation, does not suggest that she requires any acute intervention. And certainly, if we are going with symptom-directed treatment, I would actually consider use of a calcium channel blocker such as diltiazem or verapamil, and to avoid the use of beta blocker in this situation for the possibility that it might induce a spasm for what is worth. And certainly, as was highlighted earlier, the importance of lifestyle measures is going to be an important issue here.
Thanks, Adrian. This was indeed a very real-world enlightening case, and you show us how to do it step by step and very well, from the vasomotor function down to acetylcholine challenge. And indeed, this is a real-world finding where we can't absolutely be sure. I heard all the panel, I heard your take, and I would agree with everything that has been said so far. So I'd like to close from the cath lab by thanking yourself for showing us this case, to Chris for injecting so hard, as well as Jieli and Hui Wen for helping out here. So thanks a lot for demonstrating this case, and it's good to have you with us for this real life case. Congratulations to the cath lab team. Thank you very much, Adrian.
Welcome. Thanks. Looking forward to seeing all of you in person soon.
Thanks. Now we'll go on to the closing lecture, which probably will sum up some of these tips and tricks that was demonstrated by Adrian from Andy from down under Australia. He's going to talk to all the tips and tricks that was illustrated in the cath lab. Adrian, Andy, please.
Thanks very much, Jack. Can you guys hear me?
I can hear you. Perhaps
Yes.
you'd like to go to full screen.
Yes.
For your...
So that was just the protocol that we use for ACH
okay.
administration. Yeah. So what we do is we just reconstitute 1 ml from that Microvascular solution into a 100 ml bag, and that gives you 100 mics per ml. And then after that, you can use that stock solution, taking 1 ml out and dilute 10 times, and you get 10 mics per ml. And so, you can give 1 ml for 10 mics, 2.5 mils for 25 mics, and so on and so forth. So it's a little bit simpler, I think.
No, we are probably going to use this protocol as well, actually, because the other one I was afraid of putting in the wrong syringe, actually. But I think do what you're comfortable with, and having 2 persons to check through every time you dilute something is a good idea.
Yeah, I think as long as you have your own protocol, you stick to it and you're familiar with it,
Yeah, Thanks, Andy.
Let me go on to...
The easiest thing is to ask the pharmacist to prepare it for you and to provide four different files, 2, 10, 100, 200. The nurses are very happy with that.
Yes,
Very
that
nice
is our trick in Sengkang General. We're going to ask a pharmacist to do it.
Yeah.
Okay, Andy, please.
Okay, thank you very much, Jack. So thanks very much for the invitation and good evening, everyone. These are my disclosures. I received some minor honorarium from Abbott and some research support from Abbott and Philips. So, we now have a consensus document from the EAPCI suggesting that we should be performing INOCA testing. And the INOCA tests that have been sort of recommended include, the coronary physiology measurements of FFR, CFR, and IMA, as well as the acetylcholine challenge. I think Bernard presented a very nice breadth and mix of all the different physiological tests that you can use to try and look for microvascular dysfunction, and especially, the absolute coronary flow and absolute microvascular resistance measurement sounds very promising and very robust. However, it's not mainstream yet. And therefore, today I'll just be focusing on the CFR and IMR measurements to diagnose coronary microvascular dysfunction, which are the most widely used measurements. So as mentioned before, we can use the Abbott pressure temperature sensor wire to allow us to measure pressure and the surrogate of flow using thermal dilution in the coronary artery. And by doing this, we can derive these simple indices: the FFR, or fractional flow reserve, which is an indicator of epicardial disease; the IMR, or index of microcirculatory resistance, which is an indicator of microvascular status; and the coronary flow reserve, which is a composite index that looks at both epicardial and microvascular disease, and also shows or demonstrates how much more vasodilation you can achieve with hyperemia, giving an indication of the autoregulation status of the artery as well. So in terms of using the Abbott pressure temperature sensor wire, there is a proximal thermistor, which is essentially the shaft of the wire, and a distal thermistor near to where the pressure sensor is. And by detecting a change in temperature when we inject normal saline down the artery, and how the change of temperature relates to the proximal thermistor versus the distal thermistor, we're able to get a measurement called the transit time, which is essentially a surrogate of flow, which looks at the amount of time that blood takes to flow down the artery. In terms of the index of microcirculatory resistance, I won't belabor the formulation of it, but essentially with pressure and a surrogate of flow, you can rearrange the formula and get resistance. So IMA is simply simplifies to the distal pressure multiplied by the transit time during maximal hyperemia, and it gives you a measurement that indicates the minimum achievable microcirculatory resistance. In terms of coronary flow reserve, or CFR, the concept is to measure the ratio of coronary blood flow during hyperemia over the blood flow at rest, and it simplifies to the formula of having a resting transit time divided by the hyperemic transit time. So I'll, in terms of giving you tips and tricks, and I hope I don't simplify too much. Forgive me for those expert users in CFR and IMA, but I'll go through the steps of measuring CFR and IMA and insert tips and tricks along the way. So firstly, to undertake these measurements, you have to prepare the coroventis and the pressure manifold and the pressure wire. So firstly, you would place the aortic transducer at heart level, or the manifold at heart level, open the aortic transducer to air, and click 0 to 0 the aortic transducer. Next, you would flush the wire within its packaging, and then you would click the connect pressure wire on the coroventis system, and then you turn on the pressure wire to connect it with your coroventis system. And you see that orange light going steady, which means you're ready to move to the next step, which is to advance the pressure wire to the guide catheter. And a tip here is that sometimes we forget about zeroing the pressure wire in time. So if the pressure wire has been removed from its packaging, or there's a need to re-zero or reconnect the wire, then what we can do is actually place the tip of the wire, including the sensor, in a bowl of sterile water or saline, and just reconnect, use the Coroventis to reconnect the whole system there. Next is to equalize the pressure wire with the guide pressure. And to do this, we just like measuring FFR, we position the pressure sensor at the tip of the guide catheter. Remember to remove the needle introducer from the adapter this time, because we are going to need to remove the needle introducer for the IMR measurements. So we need to zero with the needle introducer out. And it is a good time at this point to flush the guide with saline, and also a good time to administer nitrates. And the pause here is to allow the wire to settle within the coronary artery, and also allows to flush out any microbubbles that may be there to reduce the chance of drift later on. Next, you click equalize on the Coroventis system, and be patient to wait for it to equalize fully before you start advancing the wire, as you can see here. Next, you should advance the pressure sensor to the distal third of the vessel that you want to interrogate. And the minimum distance from the guiding catheter is usually 50 millimeters, but preferably as distal as you can get it within the distal 1/3. After that, you would use the Coroventis system to go to the CFR/IMR page to allow you to start measuring the CFR and IMR. And this is how the page looks like, and it will prompt you to start your measurements. The next thing you should do is to flush the guide and perform thermodilution injections using room temperature normal saline. And you can see here that the flush doesn't have to be quick, but the actual measurement injections should be as fast as possible with the 3 ml syringe. A tip here is to attach the 3 ml syringe to the manifold in a place that's comfortable for you. There are various different configurations that you can do. You can put a 3-way tab on the manifold. You can hook it to the end of the manifold. I personally put it at the end of the manifold because I find that is the way I inject contrast, so it's actually easier for me. But the tip here is to make sure wherever you connect it, to carefully de-air the system when attaching the 3 ml syringe, so you do not inadvertently inject air into the coronary arteries. The other tip is to remove the needle introducer from the wire adapter. Make sure you do that before you undertake your injections. And next is to flush the guiding catheter with 2 to 3 3 ml injections before actually performing the measuring injections. And this is to make sure that you clear the coronary arteries of contrast, and also to make sure that your blood hasn't warmed up, your blood or fluid hasn't warmed up within the guiding catheter, and you're injecting actually warm fluid into the coronary arteries, and therefore will affect your measurements. So you want to clear it and fill the guiding catheter with room temperature fluid first quickly, and then start your measurements. So then you will perform thermodilution injections at rest. And you can see an example here that Adrian really nicely demonstrated earlier as well in the live case. You inject 3 times, waiting for the Coroventis system to prompt you as to when to inject. And you get 3 transit time measurements there that's popping out on the left. And then it will automatically average it for you, giving the mean transit time. If you need to replace any of the values because you think it's too far out, you can click on it and perform your injection again, and it will allow you to replace that value. Next, you induce hyperemia, and we typically use 140 micrograms per kilogram per minute of intravenous adenosine within a large bore cannula, and wait for hyperemia to be achieved. And then next, again, remember to flush the guiding catheter again before performing your hyperemic thermodilution injections to get your hyperemic transit time to allow the calculation of your IMR and CFR. Then the Coroventis system makes it very simple. In the past, when we were using the already analyzer, we had to calculate this manually, but nowadays it just pops up the value for you. What is the CFR, what is the IMR, and you can read it off the panel on the right-hand side there. As mentioned by Bernard, there's some confusion as to which value do you replace? Where do you, which one do you replace? How do you determine which one, you should accept as close enough to each other to allow you to comfortably say that you've got a good average transit time? Well, we looked very carefully at the registry data from Biopheron and from the multi-center collaborative registry data on IMR. And what we found was that, if you use a few simple rules, that you should be quite comfortable that the variation is good enough so that you don't have to repeat it again and again. And we decided as a consensus on the steering committee for the Restore MI trial to adopt this particular rule so that there is a uniformity in the what people are doing for the purposes of the trial. And for the purpose of the trial, what we say was that, sorry, here, I'll just move the screen back. For the resting TMN, the maximum difference between the mean TMN value and the TMN furthest from the mean TMN should be less than 0.25 or equal or less than 0.25. If not, the TMN furthest from the mean should be repeated. And as mentioned before, you will repeat it by clicking on the box with the value to repeat the injection. So for example, in Adrian's case, the values were very, very close to each other. In fact, one of the values 1.4 and then 1.2, you could even accept that and just take the mean. And by doing that, then you'll be more uniform in your measurements. For the hyperemic TMN, however, we accept a smaller variation because obviously during hyperemia, there is less variation. However, if all TMN values are less than 0.25, then for the purpose of this trial, and you may or may not want to adopt this clinically, but we think that the variability can be ignored because in most cases, the IMR will be not in the normal range already. So you don't really have to repeat it because the IMR, whether it's 10 or 15, 19, it doesn't really matter. If the TMN is more or equal to 0.25, as in the maximum difference between the mean TMN and the furthest TMN, if any of the values are more than 0.25, then we accept the maximum difference between the mean TMN to the furthest value should be 0.15. And if not, then we feel that the TMN furthest from the value should be repeated, and then so on and so forth. So, we sort of came to this consensus to allow us better conformity and better uniformity. Next thing to say is that after you measure the CFR and IMR, the screen or the Coroventis will also give you an FFR value. And we saw that Adrian very diligently performed an FFR measurement separate to this, that he came out of this screen and he looked at the FFR value. You can actually use the FFR value here, but you have to be careful because it is subjected to a lot of artifacts when you're doing your injections. So you just have to make sure that if you're going to pick an FFR value that is accurate, and the way to do that is to move this yellow bar using your cursor left and right, and you can see how the FFR values varies as you move the cursor, depending on in which point of the study you're taking the FFR value, and you need to choose a value where it's in stable hyperemia. So that's just a simple tip to make sure that you don't just take the FFR value on face value because it may be wrong due to the artifacts from your saline injections. Lastly, when you finish the case, you should go back to the live screen and pull back to check for drift to make sure that your pressure hasn't drifted. And we tend to accept a drift of less than or equal to 0.03 to be okay. And if it's not, then you will have to either adjust for it or you have to repeat the measurement. In terms of troubleshooting, there are three main error messages that comes out on your Coroventis system. Firstly, slow inject, which means that your injection is too slow. You're taking more than 0.6 seconds to inject. Especially the end of the injection needs to be abrupt. And that's where I think that the power injector may be a problem, because for such small volumes, if you're using a power injector, it has a slow rise before it actually achieves the speed, So I'm not sure that it's suitable for these sort of measurements. There's an error message that gives you that may pop out saying error timeout, and that means that the temperature did not return to baseline within 8 seconds. So when you're faced with that error, then you should zero the temperature and retry. You should also check for pressure damping in the guide, as there may be an obstruction to flow causing that timeout error. And the last common error message that you get is low amp, which means that the temperature did not reach the minimum temperature of minus 1 degree from your baseline, and therefore you should flush the guide between measurements to make sure that this doesn't happen. Number 2, you should verify the guide engagement, and number 3, you can also zero the temperature and repeat the injection. And by adopting these, I think 99% of the time you should be able to get a robust measurement. In terms of weird results, so sometimes you may be faced with the situation where you suddenly see a slowing of the transit time. Your first two measurements was fast, and then your last one was very slow, and you're wondering to yourself what has happened. Well, the two big possibilities. One is that your guide is out of position or your wire is out of position. Check those, check for pressure damping. And the next possibility is that you've actually caused a transient microcirculatory impairment. And this has happened when fellows have, or even consultants have injected air into the artery, causing the IMR to shoot up sky high transiently. If there's a sudden decrease or speeding of your transit time, again, verify the guide and wire position. Your wire might have drifted proximally. And lastly, then you may be facing different hyperemic conditions, i.e. your first injections or your first measurements may have been done under inadequate hyperemia. And the last thing to say here is that in most cases of INOCA, you're not going to be faced with this particular issue in that your FFR is going to be negative, i.e. more than 0.8. In that case, you can take that IMR measurement and that would be an accurate IMR measurement. However, if your FFR is less than 0.8, then it does affect your IMR measurement. So you need to use the IMR corrected value, which is on the box just next to the IMR value there, because that value adjusts for the fact that there's epicardial stenosis and adjusts for the fact that there is collateral flow affecting your IMR result. You can see in this case that the FFR is negative, so the true IMR, the IMR and the corrected IMR are going to be the same, But when you start seeing low FFRs of 0.7, 0.6, then those two numbers are going to vary and become different, and you should take the IMR corrected value. Thank you for your attention. I hope that was useful. It's just a whirlwind look at the different sort of things that you should look out for when doing these measurements.
Thanks, Andy. That was fantastic and very much what we needed in small steps and in detail. I think we'll come to an hour, so I'm going to ask our two experts to give their final teaching points and concluding remarks, starting from Bernard. Bernard, please.
Well, I just thought of a couple of additional remarks. First, we know that chest pain in normal coronary arteries is a very common situation, but we should not bring all these patients to the cath lab and perform all these tests in all these patients. And therefore, I cannot advise you enough to organize an INOCA clinic with non-interventional people involved. In the patients that your colleagues will send to the cath lab for INOCA testing, do these tests, but when you do them well. Take your time. Nurses should be prepared. And doing it well means that we have to do it frequently. If you do it every second month, this will not be done very well. And last very small tip is please record all these data, that they are easily accessible, that we can review these data even in the heart team meeting or in the medical staff meetings. And these are practicalities, but which makes the success of such a INOCA clinic.
Thanks, Bernard. Excellent final teaching points as well. Prof Koo, your concluding remarks.
Yes, so that it's great to learn about these very important issues today. That it's also surprising that more than 300 attendees are joining this session, even though the title is INOCA, not the left main PCI. So it's surprising. And what I learned and what we should learn is that, as Bernard mentioned, that this is not a simple issue. And you see how complex the whole process is in the cath lab, and it should be the combination of nurses, pharmacists, and the primary operators, and also the assistant from the patient. So that but you should remember that this disease subset is not trivial, especially when you do a patient-centric approach. So that I hope that we have all learned this issue adequately and be ready to apply what we have learned today from tomorrow in the cath lab. Thank you.
Thanks, Prof Koo. Personally, I learned that I need to learn a lot more for this space. I think today just tells me I probably need a few more webinars just to get this message across. It's still probably a huge underserved group among our patients. We know that probably up to 20-25%, or maybe even more, of the angina patients fall upon this group. But as interventional cardiologists, we're very poor doctors to address those needs. We often ignore them actually and tell them that they are fine and they get discharged. So I think we do need to learn more, as demonstrated by Adrian. It's very complex in the cath lab, lots of interaction there. And I personally don't have a grapple on it yet. I need to gain more experience using the system and to give them a firm diagnosis. Like you say, it's not always straightforward. So I encourage everyone to find out a little bit more in this space to address the needs of our patients, and they're not always running to support groups crying for help. So with that, I'd like to thank NUHCS Cath Lab, Adrian Low and his team for such a well-made demonstration for a real-life patient. I'd like to thank the two speakers as well as my panelists for their great comments. So keep in tune. I promise to organize more sessions on this space. Thank you very much, and keep safe. See everyone soon. Bye-bye.
Thank you. Bye-bye.
Thank you. Bye-bye.
Bye-bye.
Thank you.
Bye.
Bye-bye.